Sir, we are live now. With all your permission, shall we start this session?
Just 1 minute, just 1 minute. So you're live otherwise, right?
Shall I start with the introduction part, sir?
Okay, go on.
Yes, sir. Thank you so much. Good morning, all the participants present. I, Faraz from IGCP, welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Anirban Sinha, sir. And let me share some of the achievement of sir. Sir has done MD, DM in endocrinology, and he is associate professor at the Department of Endocrinology at Medical College, Kolkata, and visiting consultant at Amri Hospital, chairman at Ethics Committee, Central Hospital, SCR program chair, MMSc Endocrinology at Texila American University. And today, sir is going to discuss on a topic osteoporosis and bone health. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Yeah, sure. Thank you. Thank you for this nice introduction. And today I'm going to discuss. Uh, Let me hide the video. Hide the floor. Okay. Okay, yeah, it's working. Can you see my screen first? So we are going to discuss the osteoporosis and how it, as a clinician perspective, because we are not orthopedician, not setting up the fractures of osteoporosis, but before fractures happens, or even after fracture happens, to prevent the second fractures, how to approach the patient of osteoporosis, and that's the point. So there are many interesting stories go on that indigestion drugs can raise the bone risk, like the antacids, PPIs, and there are some hidden facts in it. Osteoporosis drugs cause microcracks and fractures. Again, there are some concern, and we can discuss that point. These are all fears of the media hypes. People see doctor fear calcium supplement, the risk of heart attack. So people, whenever they are given calciums, they're scared of taking it, thinking that calcium can actually worsen your health and heart attack risk. Dangers of more than 3 glass milk per day can be dangerous because of higher calcium risk. And then starts drinking too much of cola can cause weak bones and paralysis. They can, again, that's a different story behind it. So altogether, there are, and we definitely know that women with osteoporosis is the biggest concern, because osteoporosis is more commonly affected in women, and fracture risk increases after menopause. So these are many stories. And now, why the osteoporosis is to be talked about? Because 70% of the people over the age of 50 years, osteoporosis have never been screened and don't know they have osteoporosis. That is the biggest concern. They realize the osteoporosis only when the fracture happens. They do not screen routinely and end up in fracture before treating it properly and preventing the fractures. What is the problem? That osteoporosis is a very common disease, and over 50% of the women and 30-45% of the men. So it is not a less number, you understand. Though women is more common, but interestingly and increasingly we realize that men are also having significant osteoporosis as well as fracture more than 50 to 60 years of age. White women over the age of 50% lifetime risk of fractures, but in actually in black, the data is limited. In our country also, Asians, data is limited, but fracture is sometimes more than the white women some because of the poor nutritional status. And men over the age of 60 has 25% risk of osteoporotic fracture, and many with increasing longevity, almost 30% of the population sometimes are above the age of 60. So that increase the risk of osteoporosis and its management. 70% over the age of 80 have osteoporosis, and that again increasing in number with the longevity. So we need to be more careful with the care of elderly to prevent the osteoporosis and its fracture. Compared to the other health issues which are biggest concern to the mankind, like for example breast cancer. So these are the annual occurrences. This is the data. So we realize that from the breast cancer to heart attack to stroke, fracture risk is almost double to triple that more scary things we talk about, like heart attack, strokes, and cancers like breast cancer, which is very commonly heard about. Similarly, how the osteoporosis happens, because peak bone mass occurs around the 25 to 30 years of age. By that time, the patient is not adequately doing exercise or having the adequate nutrition, adequate calcium supplementation, peak bone mass is low. And after the 30, every decade, you can see there is a gradual decline in the peak bone mass. At the age of 60, there is a significant drop and risk of fracture and osteoporosis happens. So that is the important concept people should realize. Grow your bone mass by 50 to 60 so that it does not affect your health. But by the age of 30, sorry, so that by the 60, you do not affect your increased risk of fracture. So by defining osteoporosis, there is a systemic skeletal disease with low bone mass and microartificial deterioration of bone tissue, with the increased bone fragility and a consequent increase in the fracture risk. The true definition, what we realize and use is that bone with the lower density and higher fracture is actually considered osteoporosis. So it is not the density which matters. Fracture risk also affects by the increasing fragility and other tensile strength and other factors as well. And commonly we utilize as the BMD or bone mineral density as the surrogate marker because it is easy to calculate. But remember, it is not the only thing which matters for osteoporosis or fracture risk. So this is a simple understanding of the living skeleton. I'm not going in details where the interplay of osteoblast with filling the cavity of new bone and process takes 3 to 4 months. And similarly, osteoclasts are there to bite and use up the cells, dead cells or the bones decay. So there is a continuous remodeling of the cells occur. This is the osteocytes, stable cells inside the bone, which maintains the loading and for bone renewal, where it tends to osteoblasts and others. So osteoclasts are dissolving bones and create the cavity where the new bone formation starts. So remodeling of the bone happens. So all three components of the bone is required. This is how the cycle goes on. Bone resorption, bone formation goes in continuously, and that cycle is delayed. But I'm not going in details of the more difficult understanding of the bone remodeling. But the factors of osteoporosis is actually things we cannot change. But remember, these factors to be kept in mind to consider the risk for the patient, like gender, as I said, women, heredity. If you have a fracture history in the family, you have the high risk of fracture. Elderly age, more risk of fracture. History of previous fracture increase the risk of fracture again. Medical condition like on steroids or again many other rheumatoid arthritis and these kind of situations, Cushing's disease, these features also can have increased risk of fracture. And as medication, as I said, on steroid and other immunosuppressives, there are certain risk of fracture as well. So if you remember these factors, we should take care of the factors. Even if we cannot change, we can be careful when to screen the patient and treat them. Things we can change is that calcium consumption, vitamin D intake, or we can increase that. And normally there are data that Indians are very poor levels of vitamin D, so routine supplementation sometimes necessary in the elderly, at least supplementation with once monthly vitamin D60 is a very good option for most of our elderly population. It does not harm and better the chance of fracture reduces. Smoking is a very important risk factor of fracture, so quit smoking and quit alcohol is important. Physical activity increases the bone tensile strength. So if you stop the physical activity, fracture risk increases. Posture, poor body posture increases the pressure on the bone and fracture risk increases. Even the very low BMI less than 20, also there is a poor nutrition and the bone fracture risk also indicates sometimes. And medication we have all discussed, we can modulate them as well. Things we cause of bone loss like alcoholism, cancers, celiac disease in the gut, Crohn's disease, Cushing's disease, type 2 diabetes, rheumatoid arthritis, malabsorption, chronic liver disease, hypogonadism. We, as endocrinologists, we take this kind of things, patients like Cushing's, hypogonadism, hyperthyroidism, all these things increase the risk of fracture. Even the disorder eatings like binge eating or psychogenic bulimia, anorexia nervosa, all these things can increase risk of fracture as well. So all concept of the patient should be clear and discussed in detail. Medication which can cause bone loss is the anticoagulants, anticonvulsant, aromatase inhibitors, and androgen deprivation therapy, chemotherapy drugs, like many of the immunosuppressive drugs, cyclosporine, lithium, many of the patient mental disturbance, mood stabilizer, lithium is commonly used. And nowadays, many patients are on PPIs. As I said before, that long-standing PPI can increase the risk of fracture. SSRI, antidepressant, commonly used, and oral steroid also, like rheumatism, like for lung disease. Sometimes people take the steroid, and honestly, we miss it that patients are taking the oral steroid over the counter without the advice of the patient doctors. So that increases the risk of fracture, and long duration of steroid exposure is the biggest threat for fracture. And high dose of thyroxine, over treatment of the thyroxine, again, its fracture risk increases. Tamoxifen, premenopausal use, also risk of fracture increases. Signs and symptoms is very important because sometimes it is symptomless. 80% of the patients do not know they have osteoporosis unless they develop fracture, but it can be have back pain, loss of height over time. So patient may be realizing, or patient's family member may be realizing that patient getting shorter because of the compressive fracture of the vertebra. So patient looks shorter. We can see the picture here. And history of occasional fracture and trivial trauma fractures, even a small trauma can fracture, that increases the signs and symptoms of you are having an osteoporosis underlying. So with the age of major risk factor for fracture, so this is the BMD. So BMD of -1 almost have no fractures, but we can see the BMD of -3. So at the 50 years fracture risk is 10 years fracture risk is very less, but at the age of 60, 70, or 80, the similar BMD fracture risk almost doubles to triples. So age matters along with the BMD as well. Age of 50, as I say, T-score -2.5, 12% fracture risk. Similarly, age of 70, BMD of same 2.5, there is 24% fracture risk, almost doubles the fracture risk. This is old data, but just to give you an idea that osteoporosis established cases, some female to male, it increases from female, it is 21% from 2003 to 1 decade, it increased to almost double, the 10% increase, around 30%. Total from 2003 to 2013, again, there is a 10 million jump of the osteoporosis in the patient. So we understand both understanding of the disease as well as treatment required because of the longevity and the other factors in these patients. Does osteoporosis affect the Indian earlier than the other races? That is what which matters for us. Nordin examined the spine radiograph of apparently healthy individuals of different countries in the age group of 35 to 64, normal adults to elderly. So which shows the percentage of osteoporosis were highest in the Asian, like Indians and Japanese. Not only do have Indian have higher prevalence of osteopenia, but bone loss may also be common at the younger age in our population. As I said, the peak bone mass is less in our population compared to the Caucasian. Similar results have been reported in two other studies. Sridhar et al., the visual X-ray assessment reported 6 out of 100 apparently healthy Indians below the age of 40 have osteopenia. Although it is older data, but it definitely shows even with the no symptoms, almost below the age of 50 years, which is commonly not age of osteoporosis, almost 6 out of 100 patients are actually having the osteoporosis. Khanna Vargova studies shows 13% of 60 asymptomatic Indian between 10 to 70 years of age had osteopenia on radiological study of bones. So we may having higher risk of osteoporosis because of a low bone mass and rapid decay with the lack of nutrition and now genetic factors as well. Osteoporosis is a major health issue of elderly Indians. Osteoporosis fractures, especially the hip, occurs more commonly in Indian males than females. That is an interesting observation, though we commonly consider as female, but Indian males may be more mobile, so maybe fracture increase, and the nutritional factors matters. So osteoporotic fractures usually occurs 10 to 20 years earlier in the Indian men and women compared to the Caucasian population. Peak incidence of osteoporosis in India is 50 to 60 years as compared to the 70 to 80 years in the West. Indian study shows that 30% of osteoporotic fractures patients died within 1 year. So, what are the issues with guidelines? Because there are different guidelines from 17 and others. So, FRAX is the indicator of DEX when the DEX is needed. Just hold on a minute, maybe. Just hold on. Hello. Yeah. Sorry for the interruption. There was an emergency. Sorry. So there are Q fracture to accurate assess the age of 30 to 99, and these are different guidelines shows different calculators. So treatment initiated based on the risk assessment, and BMD is only one of the important risks, but definitely past history of fracture may be the bigger risk, and T score less than 2.5 definitely is very important factor for considering the treatment. Uh, so use clinical judgment for assessing the fracture risk. If the patient has a family history of fracture, patient has a past history of fracture, even if the BMD is more than minus 2.5, still you can consider the treatment. BMD is measure the quantity of the bone rather than the quality. So it only shows the density of the bone, but tensile strength of the bone is not shown. So honestly, if the bone BMD is high, still there is a possibility of fracture because the tensile strength is poor. Low bone density associated with increased fracture risk in postmenopausal women and also in older men. So definitely, if you have low BMD, definitely treat that. Less emphasis on assessing the BMD before starting the treatment. NICE 2070 treatment choice should be made on the individual basis because sometimes we overtreat the patient, and I sometimes see honestly any patients of fracture patient was given teriparatide at the age of 30 years. That may not be sometimes indicated if the patient fracture was because of the severe trauma or accident fall from the height, significant height. So in that situation, we do not read a routine treatment of the osteoporotic fracture. That should be kept in mind as well. Screening should be done in all women of more than 65 and more than 70 and older. Postmenopausal women of men more than 50 with the fracture at the age of 50, clinical risk of osteoporosis. Or definitely we should remember that point that history of COPD, history of rheumatoid arthritis, hyperparathyroidism, celiac disease, inflammatory bowel disease, or patients on steroids, anticonvulsant, or PPIs, SSRIs. And these things, remember, PPI, SSRIs nowadays rampantly used, and steroids are taken off level, what over the counter and by the patient. So this history is very important, history of disease, history of drug intake before considering the treatment. Remember, fractures happen in all BMD. Fracture risk may be higher in the poorer BMD, but this is the fracture rates, and we can see the BMD women with fractures are higher, but BMD maybe distribution may be similar. So there is a discrepancy in the BMD distribution and the women with fracture. We can see there is high even with the high BMD score as well. Majority of the fractures with the osteopenia, but not osteoporosis. Again, osteopenic patients outnumber the osteoporosis by 3 is to 1. So it is more less than minus 1, but more than minus 2.5. But again, these patients are also at risk category of fractures determined by not just BMD. So as I said, the age, lifestyle, family history, and the medication history, drug history, all things, and the disease history, all things should be kept in mind when you treat the patients. So osteoporosis with the clinical hip and spine fracture with the DEXA score minus 2.5, definitely treat them. And T score between minus 1 to minus 2.5, 10 years, FRAC score of more than 3% hip fracture risk and more 20% of major osteoporotic fracture risk, definitely we need a treatment. FRAX is there for almost 1 decade or more. So statistically is a robust fracture risk. Nowadays, even the Asian data is included in the FRAX score previously, which is not there. So Indian sub-ratings are available. If you calculate the FRAX score in the website, it predicts the 10-year probability of major osteoporotic fracture, both hip, spine, wrist, and humerus. Use the decision to treat again this as the fracture risk, how it looks like. put age, date of birth, disease, and past fracture history, previous fracture, steroids, and others. And this is a questionnaires definitely put it, and prior fracture definitely matters and denotes previous adult fracture over the age of after the age of 40 with no trauma. So minimal trauma fractures like excluding the toes. Definitely toes fractures are possible without minor trauma as well. Systemic corticosteroid, long-term steroid, more than 5 milligram per day, more than 3 months. Prednisolone is a very important fractures. But important factor is a secondary osteoporosis you should look for. When the Z score is -2, so then it's considered as a secondary osteoporosis. If the Z score is more than -2, so it is the primary osteoporosis. So treatment or decision again depends on the total risk of fracture, not the T score only. Specific treatment decision, as I said, must be individualized. Avoid giving the medications who are at low risk of fracture. As I see sometimes over treatment is sometimes done mostly from the orthopedic side in the fear of second fracture, but it is honestly sometimes not needed. Facts may be underestimate the fracture risk, as I again said. So some risk factors that increase the risk of fracture independently after the effect of pain is not included in the facts. They again kept in mind like frailty of the patient, very more moribund, is it not easily mobile, history of frequent fall of the patient because of the other disease, neurological disease maybe, and some immobilization, diabetes, anticonvulsant, DPIs are not included in the facts, but again, these important factors again. So there are important new concepts coming up like trabecular bone score, which differentiate between the how 3D molecular architecture can exhibit the same bone density but different trabecular characteristics. So it is actually looking for tensile strength. Low TBS score actually reflects the weak fracture microarchitecture of the bone rather than the bone density itself. So DEXA is actually shown, you can see it can look like normal, but even this is a poor osteoporotic bones here. So TBS score may be poor along with the, which can be overlapped and scaled along with the DEXA. So TBS actually is surrogate marker for bone architecture, microarchitecture. Risk stratification of osteoporosis is possible with TBS, and TBS increases the treatment availability of osteoporosis. So even if the BMD is not low, but still TBS is poor, we can treat the patient. Mostly in the patients of glucagon excess or hyperparathyroidism, we commonly see, and as well as type 2 diabetes, TBS plays a very important role because microarchitecture of the diabetic patient bones are very importantly affected. In the this situation, bone turnover markers are very important. Resorption markers, type 1 procollagen, pyridium cross-links, CTS1, and formation markers are P1NP like procollagen type 1 peptides, as well as bone isolation isoforms of alkaline phosphatase. All are done to see the treatment response of the osteoporosis. Uh, but their role in the clinical practice is not very well established because the standard limits are difficult to define sometimes. Age, gender, body mass index, all matters when we consider the range of the normal range of the patients. Laboratory variability is again important factors. Urinary NDX and serum CTX decline rapidly after starting the therapy. Maybe that is an important predictor that its patient is getting better bones. Bone anabolic agents are a very important factor when you definitely have osteoporosis and the fracture, like recommended PTH, which rapidly increase the bone formation markers, followed by the increase in the bone resorption. Both are increased. Successful reduction of bone terminal markers are defined as a 50% reduction and 30% serum markers reduction or reduced by the bone mineral marker within the lower half of the reference range of the premenopausal woman. So that is the target if we treat the patient with recombinant PTH and see the response of the patients. There are candidates of the biomolecular marker for both metabolism like osteoclastic enzyme like cathepsin can also measure sclerostin and the FGF23 are done for different turn, but tumor-induced osteoporosis. So these factors are sometimes needed in some factors of osteoporosis, but not routinely. There are different management issues like non-pharmacological management, as we know, dairy, low-fat yogurt, milk, cheese, high proteins, as well as these vegetables are very important. Supplementation with calcium in our country, as the milk intake in our country is poor. So this is the standard recommendation: 500 to 600 in 1 to 3 years of age, to around 9 to 13 to puberty around 1,100. Again, in the adult is around 800 to thousands, and more than 70 years again increases to more than thousands. Calcium citrate and carbonates are two major preparations. Carbonate is less expensive, should be taken with food, and citrate is irrespective of the food. So do not give very high dose of calcium at a single go, because body can absorb only 500 milligram calcium at a time. So two tablets of calcium prefer not to be given together. At least space it by 2 meals, so that absorbs better. Vitamin D is essential. So fatty fish, dairy fortified with vitamin D, egg yolks are very important source of vitamin D. Recommended daily allowance varies from 600 to 2000, and it's again depending on the age, but most of the time 1000 is good enough, and it can be supplemented, or at least therapeutically 2000 per day can be considered. Exercise improves the bone tensile strength and the bone functioning, because both the weight bearing and the muscle strengthening exercise can be done. Even a small 1 to 2% effect on the adult BMD has been documented with exercise, reduce the loss of muscle mass, and actually improves the strength and balance irrespective of the BMD. So fall is reduced, fracture is reduced, even if it does not significantly affect the BMD as well. Patient may have non-skeletal factor that increase the risk of fall and fracture. That is the caveat of the exercise. So we should keep in mind when advise the exercise: visual contacts, difficulty in vision, women with the disc fractures, increased risk of fractures, and flexion of the spine, lifting of the may be a problematic because of the kyphosis, scoliosis in the elderly population, and history of vertebral fracture. Definitely, weightlifting is not a good option. So estrogen in the premenopausal woman actually prevents the osteoporosis, and postmenopausally there are some trials but not very effective. Calcitonin is given mostly for the pain relief, but bisphosphonates like alendronate, acetonet, zoledronate, ibudronate are commonly used bone stabilizing agents, and parathormones and denosumabs are in the there for anabolic agents. And antiresorptive agent decrease the bone resorption, most commonly treatment given because it is easily available, not injectable in all the times, uh, like bisphosphonate, selective estrogen receptor modulators, calcitonin, estrogen, even the denosumabs are given 6 monthly, so it is very easy to convenience. Anabolic agents stimulates the bone formation, still an injectable, but works better in the very so low BMD. So it is better if you have a serious osteoporosis and fractures. Estrogen has a decreased biological markers of the osteoporosis by around 50 to 60%, and 2 years BMD increased by 4 to 6%, but again, it is not a standard treatment. Some selective estrogen receptor modulator bind the estrogen receptor, produce estrogen agonist in some and antagonist in others. But again, raloxifene have been studied. Mostly, it is used in the invasive breast cancer. But again, it improves the BMD 2 to 3% in the hip and spine. So it can be considered in the non-availability of other options. But risk of hot flashes, increased risk of other complications that should be kept in mind. Calcitonin again, 200 units daily by nasal spray. It is mostly actually analgesic effects. It reduce only improvement of the bone is only 1 to 2%. Decrease the biological markers by around 20%. There is no effect on vertebral and hip fractures have been observed. So it is mostly pain relief in the temporary part. But risk there is a concern of nasal stuffiness and risk of cancer in some studies. Treatment of bisphosphonates is the main treatment. Maybe alendronate 10 milligram daily or 70 milligram weekly. We commonly use 70 milligram weekly nowadays. Acetonet 5 milligram or 35 milligram weekly. Ibudronate 150 milligram monthly. I sometimes use that because it is a convenience for the patient. Once monthly therapy, and zoledronic acid. If you give an infusion, 5 milligram infusion over 15 minutes, that is once in a year. So patient has a poor compliance, does not turn up. Maybe once in an injection is a better option. Prevent the postmenopausal osteoporosis, data is available for alendronate, acetonet, ibudronate, and prevention of glucocorticoid osteoporosis is mostly zoledronate, which is commonly used in our country, but some alendronate is also used as well. It increases the bone density by 5 to 8% at the hip and 3 to 6% after at the 1 year, and after 3 years. Ibudronate overall no effect observed on non-vertebral hip fractures. In post-hoc analysis, non-vertebral fractures reduction was seen in high risk subgroup with bisphenoid femoral knee test score less than -3. Contraindication is hypocalcemia, creatine clearance less than 30 should be kept in mind. Sometimes GFR is important in the elderly. For oral dosing, esophageal stricture, impaired esophageal motility because esophageal irritation is a possibility. Mostly is given in the tablets. Do not eat or lie down at least 30 minutes after taking the tablets. Calcium vitamin supplementation should be given outside the time of the treatment. Class warning is the upper GI symptoms, includes the muscle pain sometimes, and jaw osteoporosis is a concern, but not very commonly seen. But tooth decay should be looked for, and caries should be treated before giving this therapy. Atypical fractures in the femur have been documented as a concern. So we look for the prodromal pain in the thigh or groin. That is the most common presentation of the atypical fracture and should be treated. Long-term treatment after 5 years of valenian decline, the BMD, rise in biochemical marker, no increased fracture risk except clinical vertebral fractures. After 3 years of hyaluronic acid, slight increase in the morphometric fractures versus clinical vertebral fractures have been documented. Cessation of treatment after 2 to 5 years is associated with some persisting effect of the biochemical markers as well as BMD. That is the advantage. Even if you stop after 2 to 5 years, mostly it is given for 2 to 3 years. So you still some residual effect there. Discontinued oral bisphosphonate treatment, there is a rapid drop due to non-acceptance, but the further decrease persisted due to multiplicity of the factors. There are concerns of bisphosphonate holidays also. Denosumab is a monoclonal antibody to rank ligand. 60 milligrams subcutaneous injection every 6 months is available. It shows the 9% increase in the spinal BMD after 3 years and 4 to 5% increase in the hip BMD. Reduce the fracture risk 60% in the new vertebral fractures, 40% in the hip fractures, and 20% decrease in the non-vertebral fractures. So this is a quite good data, but remember, effect is lost after stopping the denosumab as for the data available. Again, the concerns are with the infection, dermatitis, eczema, rashes, pancreatitis, osteonecrosis of the jaw. There are some concerns of significant suppression of bone remodeling, hypercholesteremia, and cystitis also. Teriparatide is the most important drug, 20 microgram daily. Around 2 years is the maximum duration of the most of the studies. So it is commonly given in 2 years, increase the bone density by 9% to 3%, reduce the incidence of vertebral fracture by 65%, on vertebral fragility fracture by 53%. But definitely we remember adverse event like arthralgia, pain, nausea, warning of osteosarcoma in the rats only, but hypercalcemia should be looked for if the patient is on teriparatide. Strontium granulate is not commonly approved, but there are some data, sclerostin inhibitors as well. Remolizumab are there, map for endogenous sclerostin, phase 3 trials and reduce the fracture risk by 70% quite important. Cathepsin K was initially tried, but again, it was withdrawn after oral odonactinib was there in the trial, but it was withdrawn because of the other concern like stroke and skin lesions. First, remember that BMD does not fully predict the fracture risk. So, along with that, we use the clinical judgment. Fracture protection persists even after the BMD reaches the plateau. So, BMD stability does not mean that non-responsibility. So, BMD minus 2.5 to minus 2.3 does not make that it is again the fracture risk. So, at least BMD is not worsening. That shows that you are improving the patient. So anti-disruptive agent prevents the bone loss and preserves the architecture, reduce the risk of vertebral fractures. That is the most important point. So we commonly use anti-alendronate, drosidronate, zoledronic acid, and denosumab. And anabolic agent like teriparatide improves the quality of bone, and in the serious fractures, BNB less than minus 2.5, it is the preferred drug. Patient factor determines the most appropriate drug to use. Thank you very much. What to the organizers? Hello.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. It was a very good presentation. I hope this presentation will help all the participants who have joined this session on their practice also. Sir, we have received some questions, sir. If you allow, with all your permission, shall we take
Yeah,
this question?
good.
Yes, sir. The first question is I can see is from Dr. Surana, and he is asking, What promising developments in osteoporosis research are on the horizon? What's your point of view on that, sir?
There are, as I said, the sclerostin inhibitors, and there are monoclonal antibodies, romoluzumabs, and these are drugs which can actually selectively block the osteoclastic activity. So these drugs are on trial, and that cause lesser side effects and better outcomes without significant harms. But honestly, these drugs are very expensive. Any monoclonal antibody, be it is used in immunomodulation anywhere, it is very expensive. That is the only disadvantage in our third world country like India.
Thank
Okay.
you so much, sir, for answering this question, sir. Moving forward, I can see another question, sir, from Dr. Goswami, and he is asking, are there unique challenges in pediatric osteoporosis management?
Pediatric osteoporosis are concerned with the Z score. So that is a very important, but it is very rare. Remember, it is not commonly seen. It is mostly used with the disease like rheumatoid arthritis or on long duration steroid. These are the common factors, or inherited disease, which itself causes the bone mineral density low from genetically factors. So this makes a patient concerned, but these are treated differently, and there are some guidelines independent of it. That is not a common etiology we see.
Thank you so much, sir, for explaining this question, sir. Moving forward, sir, I can see another question from Dr. Arpita, and she's asking, how is fracture risk assessed in patient with osteoporosis, and what tools or algorithm are commonly used?
As I said, FRAX is still commonly used algorithm for detection of fractures, but FRAX is not foolproof. So look for the other association like family history of fracture, previous history of fracture, as well as drugs, as I discussed, PPI, SSRIs, lithiums. These kind of drugs are very commonly used nowadays, and the drug history of Cushing's, diabetes itself, hyperparathyroidism. All these things can increase the risk of fracture, should be kept in mind when we consider the fracture risk in a patient.
Thank you so much, sir, for answering all the questions, sir. As I can see, there is no more question from the participant end. So, sir, with all your permission, shall we conclude this session for today?
Yeah, it's okay.
Okay,
Thank
thank
you
you
very
so
much.
much,
Bye.
sir. Yeah, bye, sir. Take care and hope to see you again with different topic in future also.
Okay.
Till then,